Thanks everyone for coming. Super appreciate it. On behalf of Scott Goldstein, the captain of Pikesville, I thank you for coming. For those who I have not met, my name's Sean Barinholtz. I'm an anesthesiologist and an ICU physician down at Hopkins. I'm a member here at Pikesville, and I, along with Dave Wittberg, I saw, is it here? Sorry, thank you so much. Jeff Siegel and the medical director's office, we've been very interested in organizing an EMS training series. Hopefully you guys are getting the emails. There's a whole link, now thanks to Jonathan, board meeting. All of the talks that we've given here, and there are probably over a dozen now, are available on a YouTube channel, and I send those out as part of these emails. So feel free to use those. If there's any way you can use those within your own company, that's amazing. Today is Dr. Babar Shafiq. Dr. Shafiq is an assistant professor. He's an orthopedic surgeon who specializes in orthopedic traumatology, an assistant professor of orthopedic surgery at Johns Hopkins School of Medicine and Johns Hopkins Hospital. He cares for patients with challenging acute injuries and a wide variety of chronic problems, secondary trauma. Dr. Shafiq is very active in teaching and research. He gives lectures, teaches medical students, residents, fellows on a daily basis at the hospital, as well as regional, national, and international courses. He's authored or co-authored numerous peer-reviewed publications and book chapters. His current research focuses on improving surgical outcomes for trauma patients. He's also going to actively participate in our upcoming MCI drills. I think I just got a verbal commitment to that. So that's super amazing. Thank you so much.
Yeah, I think that was like something a marketing person wrote. That's pretty...
Did you?
All right, great. Well, thanks for having me. I'm very happy to be here. I hope that some of this in-hospital stuff is really what you want to see and hear about. I think we have some time. I'm going to go through a lot of slides. I think many of you have probably gone fishing before. Those of you have, some of you might know the name of that thing that goes up and down in the water, called the bobber, and that's how you say it. So if you have trouble saying bobber, it's bobber. It's, you know, it's not spelled like that. I know it's like the elephant and everything, but you know, my parents didn't realize that when they got here. Anyway, we're going to talk about the acute management pelvic ring injuries, and these are my disclosures. Nothing related to this. The stuff in bold is kind of what we're going to go over. You guys are the pre-hospital folks, and I would imagine that a lot of you have a lot of experience recognizing pelvic trauma and then doing something about it, and we're going to go over that in the lab today just to go over the binder, which is a small part of my talk today. It's really a lot of background as to why you might want to use it. That's what we're going to try to understand most. So your role is the pre-hospital role, but you probably don't know a whole lot about what happens after the patient gets to the hospital with a pelvic injury. Maybe you do, and that's where we're going to focus today. So we'll talk about understanding pelvic stability. How do we classify pelvic stability? What do we do when we see the patient? How do we examine them? How do we image them? And there's some good x-rays that show it, and you'll understand it. And then what do we do once we've sort of defined what's going on? And then the lab later. All right, so we want to know, does this patient have a stable or an unstable pelvic ring injury? So they fall, and I can't get up, and they're hurting, and you come and you show up on the scene, and maybe it's an elderly patient, and maybe they fell from a standing height. All right, yes. Okay, game on. All right, so maybe they fell from standing height, and they have no other pain anywhere else? Want me to wait? Okay. It's like the pager goes off, you know? I have to stop surgery. Can I go? Yeah. All right. So the story tells us this is a non-surgical, non-unstable pelvis. It's a stable pelvis, we can tell. But the story tells us here that it's an unstable pelvis. You show up, you know, it's a young person, the scene looks something crazy like that. It's a motor vehicle or a motorcycle crash. They have multiple injuries. You're already thinking that this patient's going to have a high mortality rate from this pelvic ring that hurts. And if it's open, they're going to have a really high mortality rate. So we're thinking surgery in this case, right? But before we can do any of that, we got to kind of understand just some basics about it. And it's actually quite simple. It may be hard when you're trying to learn how to put screws and plates in it, but it's kind of simple to understand if it's stable or unstable. There's 3 bones, a sacrum and 2 inanimate bones on the sides. And the ligaments are what really matter here. You have these anterior sacroiliac ligaments that are like right there. And then you have these posterior ones that are these big, huge things back here. Don't need to know all of them. Then you have this pelvic floor stuff that sort of goes front to back. And then in the front you got this symphysis. That's it. Those are really the things, plus the bone, that make it stable. So when you're trying to determine whether it's stable, we kind of talk about it in just a couple different ways. Is it rotationally stable? And is there vertical stability to it? So here we have an x-ray and we see a pubic symphysis that's a little bit wide. And so this is excessively wide, and so we're thinking it's rotationally unstable because of this, the symphysis is wide. And we know from cadaver studies that that means these ligaments are torn. Is it vertically unstable? And that means if the sacroiliac joint or the sacrum itself or the posterior ligaments are disrupted, now it's got some vertical instability. All right, so if we start thinking about rotational instability and we think about it from how did it happen from a mechanistic standpoint, I'm standing, I'm walking across the street, the car strikes me on, in this case, my left side or my right side, pressed. So I have a lateral compression injury, and this is going to close my pelvis down. So the volume of my pelvis is actually going to get smaller because of the mechanism. So if you see the patient or you see the person and they've been hit by a car on the side, you're going to think, you know, maybe this is a lateral compression injury, more stable, less blood loss, because it relaxes the pelvic floor, it relaxes the vessels. This is what old ladies get, and they don't bleed a lot. As opposed to this one, where they're struck straight in the front, they're riding their motorcycle, they hit something, and they slammed into the handlebars. Now, the pelvis is going to open up from the front, and you've got stretching of the vessels. You've got widening of the pelvis, and now you've got this large volumetric space, and this is known as the open book. So if you think about the mechanism when you see them, you're going to know this is stable or it's unstable. So let's get a little bit more complicated, and we'll just fly through this. A stable injury like the old lady, just a crunch in the back, may or may not need surgery. Getting worse, you've got a couple of different fractures, and now this whole hemipelvis is unstable. You can kind of see it here on the CT scan. I need to operate on this. And then you got a windswept pelvis where they were hit on this side, and as Andy Burgess likes to say, I don't know, some of you guys probably know Andy Burgess from shock trauma. He's now in Houston. He'd say, well, we were trying to understand these injuries, and we saw this pattern over and over again where it was hit on the inside this way and then out on the other side. We thought, you know, probably the truck's hitting them on one side and then rolling over their pelvis on the other side. And we thought it'd be cool to call it a windswept pelvis. So that's how I got the name windswept pelvis, because that's what Andy Burgess wanted to call it when he had brown hair, not gray hair. All right, so when these things start getting worse, we have to grade them so we understand how severe the injury is. And we can tell all of this right away from the ED. In the first 15 to 20 minutes, we can decide what's going on here. We said APCs are worse. Here's a minor one. I don't even have a picture for it. Here's a worse one where you've got symphyseal disruption, you've got pelvic floor disruption, and maybe the anterior sacroiliac ligaments are disrupted. That results in this widening, increased volumetric space, bleeding. Right? If 3 not only has those injuries, but also the posterior ligaments are disrupted, and now you can see, man, that's enormous how big that can get. Right? And you can put gallons of blood in there. So we get an idea just off of that AP radiograph when they hit the trauma bay about what's going on. Vertical shear, less commonly seen, but this is even more unstable, where now you have the whole limb is shortening. Again, vessels are going to be at risk. Now, I don't want you to look at this, don't read it. I'm just trying to tell you here that as they were coming up with the classification, they recognized that they made their classification based upon mechanism. So that's what you guys see. Hit like this, LC injury, hit like this, APC injury. You guys get that idea when you see them. Well, based upon that, they created a mechanistic classification. Compression, anterior, posterior, vertical, And they learned that that classification correlated with blood loss, what associated injuries they were going to have, and whether they're going to die. All right, so this is a pretty simple representation of that, I think. If you were closing the pelvis down, you didn't need a lot of blood. But if you were opening the pelvis up, you needed a whole lot of blood. And this is what they identified. And so they were thinking, if I can just get an AP x-ray, and the minute they hit the ED, I can get an understanding of what I need to do to get ready for this patient. Or if on the field or on the street, I can get an idea of whether this is an LC injury or an open injury, I can get an understanding of whether they're going to not die or whether they're going to die. All right, so you can use that information for yourselves when you see patients on the street. All right, just maybe too busy, but again, just saying that the APC, the open book ones, they die from bleeding. The closing ones, they don't die from bleeding. They die from the head injury. So they were hit, they have a visceral injury, and they have a head injury. All right, so when I'm talking to the residents in the morning and I walk in, they're like the guys in the ICU, they won't let you operate on them, and I look at the AP pelvis, and I can say, he's got a head injury. I can just tell him. And I'm usually right because of the mechanism. All right, so that's some background. I think that could be helpful if you can use that to identify what the injury they're going to have. Now, I think of this as a team approach. There's a lot of people working. I'm like, almost the last guy that gets involved. You guys are the first people, probably the most important people. The golden hour is real minutes, really, but it's really important. So thank you for that. All right, I made a new Bitmoji. Does it look anything like me? Yeah? Okay, good, yeah. Well, I added the gray, But, all right, so now you've seen them and you think, okay, they were hit by a bus, so I have an LC injury, and now I got to think, okay, what else is going on with this person? They're not talking to me, their GCS is dropping. Well, you got to imagine what the other injuries are going to be. If it's an APC injury, we were thinking maybe not so many of these things, but let's see, what are the choices here? All right. Everybody who has a widened pelvis is going to bleed. So if you can see that their legs are externally rotated, or one leg is way externally rotated, they're laying supine on the ground, and one toe is pointing like it normally should, and the other toe is pointing over there, you're thinking, this is wide. And I gotta wrap this thing up. I gotta bring it closer together. All right, so if you identify that there may be some bleeding, you need to stop the bleeding. So if you identify that it's the pelvis, great. You're going to do something about the pelvis. You're going to resuscitate them. And if they respond rapidly, great. There's probably venous bleed. I've got it under control. But if they don't respond rapidly, then it's probably fluids and they're not responding, and you've given some blood and they're not responding, you have to think arterial bleed. And that's going to change our management, and we'll talk about that kind of at the end. If you've controlled the pelvis, you thought, okay, this is an LC injury, and they're internally rotated, and I don't expect there to be a lot of bleeding because they were just hit on the side, and they're still not getting stable, then maybe you need to consider some other things, right? Chest injury, abdominal injury. This patient had a lot of injury that causes bleeding, and his pelvis actually wasn't a big deal. I X-fixed his pelvis, but that wasn't really his problem. That was the smallest part of his problem. Okay. Neurologic injuries, okay, now you got an alert patient with a pelvic ring injury and you're thinking, why can't he lift his foot up? Well, that ilium is sitting on the L5 nerve root. So commonly, ankle dorsiflexion and ankle plantar flexion are lost with pelvic ring injuries because those are the two nerve roots that are really at risk. So we're not talking about spinal column injury, we're just talking about isolated pelvic injury. You might see these two things. You might see loss of dorsiflexion or loss of plantar flexion because those are the two nerve roots that are commonly involved. You see it, you're not sure what's going on, maybe you'll pick it up. That's a horrible picture. Oh, God. Right? But there's a 15% incidence of urologic injury with pelvic fractures. So look for blood at the meatus. I'm going to look for a high-riding prostate. You guys, I don't know if you do rectal exams in the field, probably not. And then we're going to do something, right? For us, we're going to do a retrograde ureterogram. We're going to stick some dye up there. We're going to see this is a normal one. That one's bleeding, right? The dye is spilling out. So we got to identify those things. You can look for it too. Blood at the meatus. You can communicate that to the team. Look, there was blood on the scene there. Don't put a Foley in. Look right away. There's something going on. Injuries, bad. Okay, it happens. We know that if we repair these early surgically, I've called OB-GYN into my OR where I'm doing a pelvic fracture and we're sewing up vaginal tears. It reduces abscesses. It's worth looking for. If you don't look for it, you don't know that's going on. All right, GI injuries, right? So open pelvic fractures or even bone fragments that cause injury. We need to do this early. If you do that early, you prevent infection. You divert that colon. All right, so open wounds to the colon, the rectum, or the perineum, you're going to need to consider diverting colostomy. Because if you don't, that's all going to get infected after I fix it. Now we're talking big problems. All right, so...
Can you talk a little more about diversion?
Yeah. So if you don't know what this is a colostomy. So I don't know if I have any pictures of rectal injury, but the ischium will fracture and it'll make its way through the rectum. And so I do my rectal examination and I'm seeing that there's bone that's come through and there's fecal matter on that bone. There's a lot of bad bacteria in stool, right? So bones don't like that. They don't have good blood supply. They get infected really easily and stay infected. When a bone gets infected, it just doesn't, it's really hard to get rid of it unless you remove the bone. So if you identify rectal and fecal contamination of a fracture, we're going to wash it, we're going to close it, but those tears don't heal very well. So that stool is going to continue making its way onto that fracture. So if you do this and you divert by giving them a colostomy, now they have all that time for rest. That rectum can heal, maybe it can be restored later, maybe not, but you can avoid really bad pelvic infection. So you have to be able to recognize that it happened, and sometimes you just can't recognize it. Even if it's a small tear in the rectum, it's important to recognize it. And then these degloving injuries are important to recognize. That's a thigh, and so I love to think about this one. This is a really common injury, actually. It happens from all kinds of falls. But I always think of it as like, I'm riding my motorcycle stops, I'm airborne at 50 miles an hour, and then when I hit the ground, my skin stops moving, but I keep moving. And so my skin shears off of my muscle layer, and it creates this dead space, and that fills with blood, and then later gets infected. So these are important to recognize. All right, so you got to watch, you got to look. If you're not looking, you don't find, right? You got to look. It's like this unfortunate child, perineal laceration, you got to recognize it. That's an open injury that's going to result in infection if you don't get all the way down to bone and wash the bone. You got to wash the bone. Right? You can't just close the wound. All right. This is an open fracture. We have an iliac wing that's displaced. That finding that you're going to see and alert us to may represent an open fracture. Again, I got to get down to the bone. I got to wash the bone, or I'm going to get a pelvic infection. And that picture we showed a second ago is this Morella Valley lesion that I was talking about. You got to do a mandatory physical examination. So this is what a mandatory physical exam is for us. If my resident doesn't tell me all of these things that he saw in the ED or she saw, I want to know why they're not reporting all these things. Why did you not do a vaginal exam? Why didn't you do all these things? It was necessary. It's important to do for all pelvic fractures. I don't know if you guys do this in the field. You do it. Okay. I'm not a fan of this. I think it's important if you are concerned for pelvic injury to palpate. Where does it hurt? Palpate the pelvis. Oh, it hurts there? Don't break up the clot. We'll show you that in a little bit, but I can't tell if a pelvis is unstable, and I operate in these all the time by doing this. Okay? I need to do it with x-ray to know if it's unstable. Right? So if I push on it, I got to do it using x-ray because I can't really tell. So, I don't know that this is a valuable thing to do in the field. Touch, feel, if there's injury there, well, protect. But what are you accomplishing by making an unstable thing more mobile? Okay? So it's best done under fluoroscopy. So, when I tell my residents that if someone's going to do it in the ED, it's going to be done once. It should be done probably by somebody with the most experience. And don't everybody go over there and start, let me feel this. Oh, like an ACL ligament. Everyone in the clinic gets to feel that ACL rupture. Don't do that with the pelvis. It's painful and you're disrupting the clot. The clot is what's saving this patient's life. Moving on to x-rays. This is all happening in the first few minutes of hitting the hospital. This AP x-ray is so valuable. I got a lot of other studies. I can do CT scans, I can get multiple views of x-rays, I can get MRI, I can do a lot of things, but all I need is that really. One view. Because you can tell that the ring is intact. And you can tell that the ring is not intact. Look how big that is. There's this big gapping and widening. So one view really tells me if it's a high-risk pattern. If it was closed in, it's not a high-risk pattern. If it's opened up, it is a high-risk pattern. That one view tells me the mechanism, lateral compression, or APC, and whether it's stable or not. So that one view tells me the potential for vessel hemorrhage. So it's really useful to get that one x-ray. And these are some of the signs of that, fractures in the front, non-displaced fractures. If they're horizontal like this, it's an LC injury, less bleeding. If they're vertical, it's more bleeding associated with it. So I can tell from one x-ray. From one x-ray, I can tell if this is an open volume of the pelvis. I can tell if there's a fracture and not a ligament injury, but yet still open volume of the pelvis. And if I got to start doing math to try to figure out what's going on here, then I know this is a bad problem. So this, cylindrical sphere, cylinder volume, I don't know what to describe this as, but we know that with each little bit of opening of the pelvis, the amount of volume that can go in the pelvis is down. We can tell if the side is intact because the sacral foramen is in line versus this elevated hemipelvis that's moving away, all from one x-ray. We can get those other studies. We probably will get those other studies. We'll need those because then we can compare those other studies to our post-operative films to make sure that everything's been reduced. All right, so this is the pelvis that's been put back together with an X-fix and some posterior screws, all percutaneously, tiny little incisions. All right. So in summary of the workup, we want to recognize the pelvic injury. We want to know if it's unstable, if the patient's unstable hemodynamically. We want to identify associated injuries, and then we want to do something for this patient. Okay? So what are we going to do? And I'm moving kind of quickly, but I love this set of words: pack, wrap, warm, fill, squirt, and divert. If I follow this, I love it. And I thank Ray Wright from Kentucky because he's the one who taught me this. Great trauma guy. Pack, wrap, warm, fill, squirt, divert. All right. So pack open injuries. You guys can do this. Find an open injury, pack it, stop the bleeding. Wrap them. All right. So we'll talk about the different ways to wrap them. Warm them. All right. Give them a blanket. Give them some warm IV fluids maybe. Resuscitate them, fill them up with some fluids because they need it. If you can't control the bleeding, get them into the angiography suite and embolize the bleeding, and then divert the colon, which is what we just talked about. So pack, wrap, warm, fill, squirt, divert. Thank you, Ray Wright. All right, so this is packing. We've got this rectal injury. Take some gauze, give him some antibiotics, and check his tetanus, and give him some tetanus, but pack it. Pack the open injury. Pack the belly. Pack whatever you can pack. Pack it. Okay. And then wrap them. All right, so get some blood clot to form, and then squeeze together to decrease that huge volume that I showed you, that big, huge cylindrical, whatever it's called. I love the sheet. The sheet's my favorite. I really do not like the binder, but they live in my hospital, and so everybody gets a binder, and the trauma surgeons, the residents are all excited, and I'm like, all right, take it off, put the sheet on. because I can work through the sheet. The sheet's much more useful to me. But either way, both of them they're easily applied, they're portable, they're versatile, and you can see, put something on, it closes down and tamponades the bleeding. That's what it does. That's the goal of wrapping them. That's an old binder from some old Google image. You guys are gonna have something nicer, I'm sure. Again, my preference. Where do you put it? You apply them to the greater trochanters and over the symphysis pubis. All right, all the time we see this. I'm so glad. What we like to say to our second-year orthopedic residents is that by the third month of second year, you know more orthopedics than anybody else in the hospital. Right? And why is that? How do we know that? It's because when the binder's placed up here, you're just compressing the belly. You need to push the greater trochanters in to squeeze the pelvis down. So that's how we're going to apply it later today. Where'd he go? No, he says he's going to be here. We're going to do it later today. How do you do it? Well, you draw a picture on your resident, and you mark the iliac crest, and you find the greater trochanters. And then two people, all right? So you sort of fold the sheet, and one person's holding one hand, the other person's holding the other hand. You can really get tight on this. It's so easy, much easier than a binder and all these little Velcro things. So here it is. Don't do that. Right, that's not good. The reason that's not good is because this patient's going to swell and swell and swell, and they're going to get skin necrosis from those thick lumps that are on their skin. You want a broad surface area contacting the skin. All right? So don't do that. They're perfect for ABC injuries. They're not needed for LC injuries. If you think you have an LC injury, you may not know, you're in the field, you're pelvic injury, you want to save their life. But if they're hemodynamically stable, they have a fall on their hip, it's a geriatric fracture, you don't need to take the pelvis and push the fracture into the bladder. But if you're not certain, put it on, because you're going to help them if they have something like this. All right? Another way to wrap them is to put on an external fixator. All right, so this is just a simpler version of or easy, I don't know, to me it's easy, but what it does, same thing. Decreases volume, holds the hemipelvic together to tamponade the hematoma. So I think that's a key point I want you guys to get, is that if I'm going to test the stability of the pelvis to see if it's unstable, what am I doing? I'm breaking up the hematoma. I'm causing bleeding. This thing is a wrap, prevents motion, keeps that clot stable, and if you have to transfer them, they're going to be a lot less pain if you do this for them. All right, so pelvic X-Fix is really good for open fractures where the sheet or the binder is in the way. You get, or when an X-lap has to be done and you don't want to leave a binder on somebody. Or if the binder was unsuccessful for whatever reason, you couldn't get it on right, didn't fit, large person. And for me, one of the things I like about the sheets here is that I can put this X-Fix on right through the sheet. So you guys put a sheet on, I can't really cut that binder very well. It's very difficult for me to cut it, but I can cut any hole I want and do percutaneous pelvic fixation like this, including the back screw right through the sheet. You can see, put that back screw right through there, and put those X-Fix pins in right through here, and sheet's very useful.
Is there a substitute for the clamps? We don't have a lot of clamps.
He's going to steal you some clamps. Yeah, so that's a good question. I don't really know.
It's not going to cut.
Probably not strong enough. A vice grip would work if you got yourself some vice grips.
Are those curtain clips?
Sorry?
Are those curtain clips?
These are towel clips. These are hemostats, straight snaps.
The previous photos. And the towel clamps,
yeah, those are skin towel clamps, yeah. But you can do it with anything, so I think a vice grip would probably be useful. But I don't know why you can't stock these in your vehicles. Money?
We have the commercial binder. Our protocol is written specifically for commercial binders, but if you'd ever like to come to a protocol committee meeting, I think which is riveting.
Yeah. Okay. I'd be happy to come and say, give them some clamps. I just took a basket full of clamps that I, took from Africa. Sorry?
You can email Andy Collins.
Yeah, I'm sure he's got access to them. I know he's got access to them. That's interesting. I mean, these clamps exist in CVS. Yeah, he's got. Where'd you get yours from?
They're great for holding up the drapes.
Yeah.
Sorry,
I think it'd be useful. All right. Warm them up. I haven't bought one of these yet, but I'm told they're pretty good. But warm up the patient. You guys know this key prevents the triad of death, right? Coagulopathy, hypothermia, acidosis. You can do that with IV fluids too. Fill them up. All right, so we're going to give them IV fluids. These are parts of that protocol that we can do. Blood products, FFP, depending on your institution, and we do 1-to-1-to-1 most of the time. Squirt them. We talked about squirting them. So here's a case of an angiogram. So you see all those vessels that are lighting up with contrast. So if you have a patient who's got is hemodynamically unstable, you've tried to resuscitate them, they've remained unstable, then they may have an arterial bleed. All right, so of these patients, still only 10 to 20% of them have an arterial bleed. Most of them are a venous bleed. Take them to angiography, coil it. So here's some coils. You can find those individual blood vessels and just plug them up so that they stop bleeding. But this is not always that helpful. I mean, sometimes it is you saving a life, but it has consequences because you can spend hours in angio, killing the kidneys with all that contrast you're putting in. If you occlude one of the major blood vessels that comes right through here, the one that gets torn a lot, or when it gets torn, that's the one, then the whole muscle can die. And so then can't do surgery through that window. And then you get wound infections if I do operate through that area. So angiography has problems. And divert, okay? So that's the last thing. What was it again? Pack, wrap, warm, fill, squirt, divert. So you guys can pack them, you guys can wrap them, you guys can warm them, you guys can fill them up. We'll do the other two things, okay? But you guys can do all that stuff to help. Thanks, Ray Wright. All right, so summary of our management is it's a team approach. We're going to get the right imaging once they hit the ED. We're going to identify the high-risk fracture patterns. You guys can do that too. Once you've identified them, make sure you look at other injuries and don't miss other injuries. Don't look at just the distracting injury. Take your time, do a full exam, and look for other problems. Wrap them up, fill them up. Look for other sources of bleeding, and then consider, X-fix or angiography, which is what we'll do when we get to the hospital. Okay, so expect the worst and hope for the best. Thank you.
Great. Any questions? And then we'll bring the practical stuff, so we'll reconvene and...
Sure.
As you receive patients from EMS in the trauma bay, have you ever seen cases of incorrectly applied binders, and how often, and what's the consequence and common mistakes that are made?
Yeah, so the most common mistake is putting it too high. The problem is that you're not achieving your desired effect of closing the pelvis down. And yet you may then stop thinking and rest, thinking, well, I've done what I can do, and yet you haven't. So that's the number one problem, is placing it too high. The short term that it takes for you guys to usually get to us, you don't really do anything else that's bad by placing it too high other than not getting the desired effect. If it's placed too long that way, then you'll get skin necrosis over the iliac wing. So that can happen where instead of putting pressure here, you're putting it on the ilium, and that skin's dying as they're swelling. So that happens longer term. So we'll be diligent to take it off, move it, slide it down. And even when we get it on, I'm looking to get an X-fix on. I'm looking to get internal fixation in hours, within that first day. And if I can't, I want that X-fix in place. so that I can take the binder off the skin.
I have a couple of questions. I had a patient one time with a pelvis and femur fracture on one side.
Yeah.
The first thing you saw was it looked like he had an obvious femur. We didn't know about the pelvis until we got the x-rays and showed trauma, but what do you do with that?
Yeah.
Sling, no sling, binder?
So we have hair. So is that what you mean by the sling? Sorry?
With a pelvis fracture?
No, so I'm saying you can't use that.
Right, I was just going to say.
Yeah, so you won't be able to do that.
Right.
What splinting materials do you have? What immobilization do you have besides a binder and a hair traction device?
Longboards.
Longboards. Okay, so tape them to a longboard. You strap them or tape them. What else? Backboard. Anything else?
KD.
Sorry? KD.
KD.
Oh, KED. Okay. Well, I think if you tape them to the longboard after you have the binder on, you'll secure the femur, but there's not much else you're going to be able to do. What we would do for that is apply traction. So we'll put a pin in the femur, put a pin in the tibia, and give them traction. The hair traction has to have fulcrum off the ischium, and you can't do that on that side. So if your question is, what do? I think you bind the pelvis, you tape them on the hardboard, on the backboard, you get their limb oriented, and you bring them in. But the pelvis is going to take priority. So that's what you need to do.
And as far as assessment goes, we were taught to push and see if there's movement, in the pelvis.
Sure.
What, in the field, what would you recommend that we do?
So
we know.
So what has that done for you?
Made patient screening.
Yeah. Right. So who is an advocate? Anyone say, like, I have a reason, I thought it was useful?
That came out as a book, The Maryland Way.
Yeah.
It's the same thing, if the pelvis is built, you try it once and then you're done, and then you put your pelvic band on it, so you're swinging, and then you advise the trauma center that you suspect a pelvic fracture. Just one time.
So they're laying down, you push back?
Yeah, gently, and if there's any movement, you stop.
So down and out?
Right.
Okay. All right, so, I would suggest that what you're doing is you're taking that APC injury, if that's what it is, and you're increasing the pelvic volume.
Yeah, I'm no argument.
But you could palpate, right? So you could touch the SI joint on one side.
Generally, if they're conscious, they'll tell you.
Yeah, okay. All right, so unconscious patient, you're going to look for some pelvic instability. Do you feel confident like you felt it?
It's hard to tell.
It doesn't feel 100% sensitive.
Yeah.
That's for sure.
Right, so, I think I'm telling you that you can't do it. I'm telling you, I don't think it gives you a lot of information.
So I think this is a great reason to invite all of your friends to these lectures, because before I became a physician, I was a paramedic, and I was raised, during the trauma assessment, pushed down, and I think all of us were looking at our national registry. And now that we actually sit down and talk about it, it's nonsense, and it will open up an APC fracture more widely. And so I think it's important for us to question things when they don't make sense. And the guidance we received when we took our whatever ENT or PD exams, and it may not reflect best practice, and that's why these lectures and lifelong learning is important. The other thing I would mention, looking at the state protocol for pelvic binders, which is an optional protocol that we're allowed to use in this jurisdiction, is that number one, it doesn't exclude you from using a towel or a sheet. And number two is that it just says if there's a good mechanism of injury that would support this patient potentially having a pelvic fracture, put on a binder.
Sure.
You don't need to do a detailed exam.
And I've recently researched this topic, and I couldn't find any studies that showed more positive outcomes for using a binder versus just using a sheet. Now, given we don't have a way to lock them in place with hemostats like you do, but there's no data out there that supports the use of binders over sheets.
Sure. It's somebody's making good money off those binders.
Question: is there, if we suspect that it's a lateral strike versus an APC, is there any benefit in maybe just internally rotating the thighs and taping them together?
Sure.
Versus using a pelvic binder?
Absolutely, it does help.
Yeah,
All right,
or should we consider trying to internally rotate when we use a pelvic binder? Like, do you think that would offer any more benefit, or if it's not worth it?
absolutely offers more benefit. So the way I do it in the operating room, we put it between the feet. I don't know if you can see me, but you'll take your feet, which are doing this with their pelvic injury, and we'll put something cylindrical between the legs and then tape the feet to that. So it's not feet to feet, it's feet around something round that's soft, and absolutely it closes down the pelvis through the hip ligaments. It's very useful to do that.
My concern with putting a sheet around a patient is you have to get underneath them, and there's a fair amount of manipulation with that.
Yeah.
It just seems like you could do more harm than good by just manipulating them instead of just putting them on a scoop and a backboard.
Yeah, I mean, log rolling is not that traumatic. So you can do a sheet by doing a log roll.
Okay.
You know, and log rolling is very safe to do.
Okay.
Holding inline position of the neck and getting good control of the spine. The sheet gets pretty flat.
The other thing is you can squeeze it behind the knees or the small back and then shimmy it up. That works well.
Yeah, that's a good idea. Yeah. Any, sure. I got one question though. Tell me, if anyone wants to tell me a bad or interesting experience they've had with a pelvic fracture. They can remember some experience. Okay.
It's not their only, at least ones I've seen, it's not their only injury.
Okay.
Pretty messed up.
Yeah, so there's a lot of polytrauma.
I was explaining to you before, we don't get the results as we used to back in the 80s and 90s when we sent somebody to trauma. I think it would tell us the real outcome, what we found and what we didn't find. So
Okay.
we all have bad accidents, but we don't would been told. Unless we know somebody who works there.
Yeah.
It tells us the real outcome.
Well, if you bring somebody to Hopkins and they have a pelvic injury and you want to know, you can take my phone number down tonight and I'll be happy to tell you. Just send me a text message and I'll be happy to communicate back. All right, 5-minute break.
All right, Calvin, find a partner. At least I know it's fresh in your mind. All right, so we arrived on the scene. We have a patient that's, we'll call him in his late 60s, early 70s. Patient fell from a standing position onto a padded carpeting floor. We've arrived for a patient complaining of pain in his left side. All right, so we've arrived. So just walk through, just start treating your patient. So walk through the whole.
Okay.
Sir. Okay. Patient's conscious.
Okay, so start talking to the patient. Hi, my name is.
I'm Yako with the fire department.
How you doing?
Can you tell me what happened?
I fell down while I was painting the roof. I was on the ladder.
No, you fell from a standing position on the floor. No, this isn't big trauma. Little trauma. We'll get to big trauma.
That would be easy. So you feel any pain anywhere?
Yeah. Right here.
Okay, so we're not gonna palpate. We could palpate just lightly.
Well, so hang on a second. Why would you palpate lightly? If he's already telling you he has a pain there, the whole purpose of palpation is to find pain, correct? All right, so he's already done that part of the assessment for us. So now what do you have to decide for Calvin to do? What's your next move here?
Yeah, you want to go get some towels and cravats.
Ooh, hang on, nope. What should he be doing? So what do we think is going on here?
Either. Okay.
It's either a...
So it could be pelvic or hip?
Hip or pelvic injury, or either one of those potentially life-threatening. Yep, which one?
Pelvic.
Okay, definitely more of the pelvic. Why?
Could bleed more.
Okay, internal blood loss. So if we believe it to be a pelvic injury and that's going to be serious, what do we need to do right away?
Oxygen.
Okay, we'll get to oxygen in a second. I'm with you on that. Absolutely start treating for shock. But from a partner point of view, what's your next move?
Oh, stabilize.
Yes, we need to stabilize. So if we believe it to be a pelvic injury, what type of a hold do you want to put on there? Are we holding the joint above and below, or are we putting more of a compression type hold on there?
More pressure.
A compression type hold because we believe it to be pelvic in nature.
So it's like
And out of those two, that's the more serious injury, correct? So if we stabilize for the pelvis, legitimately, if that doesn't move, we should be able to minimize the hip movement as well, correct? All right, but most likely they're not going to die from a joint injury per se. We all on the same page with that? All right, so he's going to go ahead and stabilize. Essentially you have your assessment. You want to put your patient on oxygen. Got a priority for him?
Priority 2.
Okay. Do we need any other resources? Or are we good with this?
We shouldn't need other resources, right? In terms of...
Do you guys feel strong? That's fine. I mean,
I think we can handle it, but...
Okay, so you're considering it, but so you guys are comfortable, the two of you can handle this, and... Okay, we're good for that. Where are we taking our patient?
A trauma.
To a trauma center, absolutely. Level 2 trauma center is fine, but they're definitely going to a trauma center. Okay. All right, so we have our partner stabilizing. You can finish out the rest of your assessment, get whatever other information that you need, and now we're to the point that we want to go ahead and stabilize this injury. So what are our two choices?
We can either use a pelvic binder, or we can pad it between the legs and tie with cravats.
With the cravats. All right, so standard EMT, 4 cravats down underneath, roll a blanket, put it in between the patient's legs, move the good leg to the bad leg, and tie them all. How do we tie them? Distal to proximal, proximal to distal? Proximal to distal, and we'll show you that in a second. So if you want to use that pelvic binder, you're not done your assessment, are you?
No, because you need to ensure 100% that...
We really want to make sure that hip's not involved, because if we put that pelvic binder on, what's going to happen if we got significant hip pain? It's probably going to make it a lot worse. So is there anything that you can do? So again, it's his left side that's injured. Is there anything that you can do to kind of help rule in or out whether we think that hip is involved?
You could look at the length of the...
Okay, so length is one. Absolutely. What else?
Slightly turn into the joint.
So we can slightly rotate. So with him stabilized, you can come around the left side. All the way around.
All the way. Okay.
Patient's left.
Right.
Keep coming. So come up, put one hand at the top of up at his hip, your right hand up at his hip, left hand at his knee.
Okay.
So all we want to do, and maybe just right below his knee, so all I want to do is a very gentle rotation. All you want to do is watch for any kind of facial indication that's causing pain, any crepitus, any resistance. If we don't have any issues with the hip moving, and again, it doesn't have to be a whole lot, a couple millimeters, just enough. If we have crepitus or anything else, I'm going to go with an old-fashioned 4 cravats and not put that pelvic binder on because I don't want to cause that kind of pain.
And it's an internal rotation, correct?
Honestly, it shouldn't matter, but typically I would kind of rotate this way, but again, really shouldn't matter, because again, all we're really trying to feel is crepitus and is it kind of moving on its own or not. You should, all right, so he has pain, we're going to bail off the pelvic binder for a second. Let's get our 4 cravats and a blanket set up. Okay. Should be right behind Giz. What other equipment do we need out of the ambulance for this? Orthopedic stretcher. Possible longboard. Again, he's not really pushing the edges of it, but your scoop stretcher, how much does it weigh? If it's completely closed up, what's your weight limit on it? So that's your scoop stretcher. For those that don't know, if this thing is completely closed, how much can I lift with that right now? 350 pounds. So now there's 3 holes that I can extend this to meet the length of my patient. Every time you guys see one of those holes come out, you reduce its lifting capacity by 50 pounds. So that's why he said that backboard may be needed. You may need a scoop stretcher to initially lift him just a couple of inches, and then somebody to put that board underneath. If we're going that route, you need at least 2 people to come help you. This will be on a 2-person operation. And quite frankly, for the amount of equipment we have coming in and out, so I would have put the cravats down before the blanket. Now you just got to fight that a little bit. Now the other thing you guys want to make sure we do is it wants to be, and you sort of have, it's going to be a little bit wider at the bottom than it is at the top just because of the space you need to. How close do we need to tighten his legs up? Do I need his ankles touching each other? What do I need to do? Just get everything in line. So my padding needs to make sure that that happens. So I need to make sure I have enough padding in there so I can't over-compress it. Do I want these cravats real wide or real small? Wide. That's correct. So let's get 4 of them down there, 2 above the knee, 2 below the knee. Now I would keep those rolled up just the way you have them right now. Take them underneath the knee, because that's going to be your void.
Oh, yeah.
So 2 above, 2 below. Once you get them in there, then we can worry about making them a little bit wider. But let's get them in place first. Now, why would this be an ALS call? So potential for pain management. What else? If you told me that you're worried about him losing blood, don't we need an IV?
If you're not an IV tech, then yeah.
Okay, what else might make you call for ALS for this patient? Okay, so a little bit more medical history. So let's go into medical history. Was he dizzy, lightheaded, medication changes? Absolutely. So talking to him will absolutely indicate that. What would change the way that you handle this patient when you're talking to them? If they start having an altered mental status, if their answers start changing a little bit, so things we need to be aware of, because yeah, they may be okay now, and they complain they didn't hit their head, so as you're talking, we're constantly evaluating. What other concerns when you're talking to your patient and their history starts giving you concerns about this patient? So if I give you somebody in their late 60s, early 70s, what are some other concerns we need to be thinking about when we're doing our assessment? Okay, medications specifically. Do we have blood thinners? Do we have any kind of bone disease? Any kind of recent surgeries? All right, so we roll that up nice and long. It's going to be wider down at the bottom because, again, it's going to come up to into his crotch. We want that kind of high up there, so it should almost mushroom out down at the bottom.
Probably would have spent a few more minutes asking him under his head.
Right. So we said go through your assessment. So go ahead and you can kind of fold that back on itself a little bit, and that'll...
Do that.
Or actually, I would have bent it. That gives you a more hard fold. So lay it all the way out, make a U out of it.
Okay. Like this? Or other way?
Yep. I would bring it in more like this. That's a little bit more tough when you bring it together, because again, I don't want those ankles touching. So we're going to wrap this, what we said, proximal to distal. So now's where you can make your cravats a little bit wider, and that's why it's nice to have some extra set of hands here. Because when's Calvin allowed to let go? Once all 4 of these cravats are in place. You might want to make this one a little bit wider, and this is the one that's going to put good compression around his pelvis area. So this is the one I would try to make a little bit wider if I could. Can you guys spread that out just a hair on the sides before you tie it? And if we cannot get directly over the blanket, you will have to pad that knot, but ideally we're going to get directly over the blanket. Notice when he went down there, I saw his hands go down there, but his shoes would have been off, his pants would have been off. You would have assessed PMS prior to putting any of this down. So where are your level 2 trauma centers? Where are you taking this patient? What's level 2 around here? So Sinai's level 2. Depending upon where you are, what are some other options to take your patient? Where's your level 1 centers? All right, so Hopkins, which one? Downtown. They are both not level 1. What is Bayview? Bayview's a level 2. What is Bayview's specialty? Burns and? Well, Burns and then, I guess secondary for, they're level 2. And give me another level 1. So what's the other designation for shock trauma? It's definitely a level 1 center, but it actually has a special designation. A PARC, a primary adult resource center. What does that mean? In the hospital world, what does that mean?
Many people on call 24/7 specifically.
So they can handle everything internally. From the time your patient comes in, they can handle everything under one roof, including rehab, before your patient's discharged. So there's only a few of those in the country. So we always move good leg to the bad leg, and never over tighten this.
Yeah.
Any questions so far? Doctors, any input, anything I've missed? Anything questionable that we've said or done so far?
So explain to me again why you have a suspected hip injury, you want to avoid the binder.
So when we went through the training, we were told that if we put it on a patient that has obvious hip injuries, the pressure you put on there, is probably going to be unmanageable pain, and because this is just as stable as a pelvic binder, the indications were to go this way.
Great. I guess the challenge for me would be to think, well, if I have a hip injury and a pelvic injury, how do I differentiate between the two?
So the only way that we can really do it is that little bit of movement to feel any crepitus that positively indicates the hip's involved. Otherwise, there really is nothing else in the field that I'm aware of, which is exactly what I'm asking you, is what did we miss?
Yeah, okay. So I guess what I would say is that if you can feel the back of the pelvis.
Go ahead.
The hip is going to be on the side, but you can get to the back of the pelvis and feel if that is painful.
Okay.
And if it is, you're going to be thinking more of a pelvic ring injury. All right, so if you get behind where that sacrum is, where the sacrum meets the ilium, you can distinguish that between that and a hip fracture. All right, so it may be helpful to say, okay, I've got a patient in extremis who is losing blood pressure, needs more stability of the pelvis. I might forego worrying about the hip.
So if he's unstable, correct, right, because the blood loss would put you down more that pelvic injury than the
allow
hip.
me to go right to the pelvis.
Awesome. Now what about where the cravats are placed? You good?
Yeah, they're great. So they're not at the joints themselves. They're in the muscle bellies. So you've got surface area at the calf, at the lower leg, and then the thigh. So I think they're placed well, just below the hip itself. So we're in a good position.
All right, guys, grab a scoop stretcher. Let's get your patient on there. Let's go over this real quick.
All this will go with 10 minutes scene time.
Say again?
All this will go with 10 minutes scene time.
Yeah, in second thought, I would have gotten the engine just because it's so labor intensive.
Correct. That's why we're going through this. So keep this together. Keep it together. Lay it next to your victim. Let's pick it up and not drag it across the floor. Thank you. So you always want to measure this before you separate it. You want it to be a little bit taller than the victim.
Yeah.
Well, if they're my patient, they're a victim.
Yeah. So we have a good question. The question is, wouldn't it have been better to use a sheet because it's a larger surface area? Is that the question?
As far as what? Wrapping it on the very top?
Well, using a sheet instead of the cravats.
You can. I'll be honest with you. We probably tend not to have half dozen sheets available so quickly like that.
Part of class reading it because he's advocating telling your clamp to clamp the sheet in place.
I think
That's cheaper than belt.
Which is, again, I told him I was going to come out here and do what we normally teach in class and let him kind of build on what he was.
No, I want to just be clear. He said in the beginning this is a fall from standing height, so it's a low energy injury, and we're more suspicious of a hip fracture than we are of a pelvic ring injury in this patient. So we want to avoid excessive pain by going to a sheet. Whereas I think the next scenario is going to have a different presentation.
Correct.
So
we want to do one of each.
Pelvic ring injury.
All right, so you guys are happy with this thing being measured? You only see 3 of those holes? Yes?
Yeah.
What happens? Open it up again and keep pulling it. Show us what happens if you extend it past 3 holes. Does it bend in half? Yep. You can bend it at that point.
Yeah.
So let's lock it in place so we can't go, the maximum you can get this down is 200 pounds. Are we kind of right at the patient's weight? We think he's pushing 100 kilos?
No. I mean, well, not 3, you said 3, max is 300 pounds?
It was 350 shortened up. You have 3 holes showing, you lose 50 pounds for each hole, so now you're at 200 pounds. Does your patient weigh more than 200 pounds? If so, the key is we want to lift them and put a backboard underneath to support it. But we're still going to use this because you're not going to log roll them. All right, go ahead and separate it. Decide which one he's going to pull it. Pull your end. Take it to one other side of the patient. Do not lift it over the patient. All right, both of you get on the side of the victim. Start pushing that thing in. You can put his hands up on his belly. Get him up out of the way. Now, Yakov, you need to be on your side.
Possibly tie with a cravat for the hands.
Nah, he's conscious. He's talking. He's fine. So do not impale his head.
Okay.
Who's on the ambulance? Okay, good. Now you. Keep going. Don't impale his head. Now stop. Who's got the injured side?
I do.
Good. Put your hands face down. Fingers, one hand down by his butt, one hand up by his shoulders. Down underneath so you're touching the board itself.
Okay.
No. Hands down.
On here, right here, okay.
Yep. Now, you're going to put your both knees on the ground to keep that board from moving. Now, as he shifts this in, you're going to start picking up skin and tissue and clothes so it doesn't get pinched.
Okay.
So you're going to do the same thing. Put your hands down, butt and shoulders. Start pushing it in with your knees as far as it'll go.
Okay.
Now, keep your knees, Calvin. Keep your knees together. Slide up to the top of his head. Pull it in. Close it up. You can let go. So,
Head needs to be picked up.
Yep.
sir, lift your head. He's conscious, he's listening, make him do something. Put your hands back, Jakob, you're not done.
Okay.
Calvin, you slide all the way down, keep your knees against the board, keep your knees against the board. So you need to be active. Get his body and butt up out of the way. Do not let him get pinched. Minimal movement to minimize pain. Are you getting pinched, sir?
Yeah. No.
So you need to say something, sir. Unless you're enjoying it, you need to say something.
That's not supposed to happen. Right. There we go.
Right, that's why you're under there, is to keep that from happening. Watch your patient's facial expressions.
Still getting pinched? Good.
All right, so at this point, we're not going to. You can lift him, put him up on the stretcher, because he's not going very far, so you don't got to secure him. We're just going up to the stretcher or onto a backboard and up and over, and then we're good.
You say onto a backboard,
And then,
orthopedic onto a
like,
backboard.
two of us would be on the ends. You lift it, third person slides the board underneath,
And then
lift them back down, then we lift them with the backboard, because you've already maximized the rating capacity of this. So, because you don't want to, because if we lifted him, it's going to bow in the center real hard, because we're right at the maximum weight limit on this. So, again, you just use that to reinforce it. Leave this under the patient to when you get to the hospital. A lot easier to pick him up, move him with this, than to try to have to lift him and move him with sheets, which is going to be real painful. And the other thing is, watch pain level. Do not worry, call for ALS if you think pain management's an issue. Okay, let's go ahead and get him out of there. All right, new patient, new team over here, please. Let's grab that pelvic binder. Outstanding. All right, she needs a partner. Dovey, you want to be the patient? Sure. All right, Peyton, step up. Let's go. Have you used these before? Oh.
I use a sheet.
Got it.
Bang, you're dead.
In the hip.
Bang in the hip.
All right, so we have an unconscious trauma patient. We've got somebody holding the head. We're starting to do our head to toe. Once you finish up the belly, go ahead and show me a pelvic assessment. So you've done everything all the way down to his belly button. So we stop right at pubis emphasis. So take it from there.
So we already checked all that?
Yeah, we've already checked everything, so we're just going to focus. You've hit the belly button, and so far he's just unconscious. We don't know why.
Okay.
So, but it's a significant trauma with the fall.
Okay.
So we're holding his head, got C-spine, got a collar on him, got oxygen on him. You're now down to the pelvic assessment. Okay. So there's three ways we assess the pelvis. Starts with heel of your hand, pubis emphasis.
Yeah.
So go ahead, start there. All right, so when you do that, you feel some crepitus, or you feel something weird going on underneath your hand.
Okay.
Is that enough to stop your assessment?
Yes.
Yes? Now, if it felt normal, no issues, no painful expressions on his face, then will be your next step in the assessment. So we can gently do a compression to see if that elicits any painful responses or any kind of crepitus. Go ahead, have at him.
So push in.
Okay, and then we can gently push back if we feel things start to butterfly open. So we do feel some things that are weird there, and you are concerned about patient's pelvic stability.
Okay.
So what are your options? If that's the only injury that we find besides them being unconscious, what are your options? Because if your patient was hit by a car and we find the pelvic injury, what's your only option?
So put him
on a backboard, go to the hospital. Yeah. Right, we'll treat them en route, especially if that's the higher level of trauma. But this, we're not quite sure why he's unconscious, other than he did take a fall, and so probably a head injury, but the pelvis seems to be of a bigger deal. So, fortunately, on this kind of a floor, it's going to be a lot easier. When we used to do this on carpeting, it's kind of difficult. So, again, we're going to slide this under the victim's area, and we're going to kind of bring this up. Now, should we have somebody stabilizing? Yes, that's why we actually got, so we have extra people here, so go ahead, you guys get that in place. I'll step down here for a second. So how do I want to stabilize this? So if it was a pelvis, we stabilize like this. If it's just a hip injury, it's the joint above and below, right? Okay, so go ahead and work around me.
If we're going to if we're going to clench this down though, is there a purpose in adding a compression when?
Well, I'm doing it until you guys get this in place. So once you recognize that injury, I should stabilize until you guys are ready to put this in place. Then you guys, once this is in place, you guys are taking over for me. All right, so bring this around, hold the Velcro in place. So hang on. Bring this about here. You pull one that way, another hand here, pull it till you hear a click, secure it in place, and that should put the proper pressure on there. We're not done. Now what?
Distal pulses.
Reassess PMS, and we're still not stable. Wow, we got a board. We're going to board, absolutely. What else? Legs. What are we going to do with those? At least a single cravat. I would like something in between because I don't want his legs so pressed together, but we do got to secure it so the legs aren't flopping all around.
Great. Yeah, so when I'm trying to move a bone, I always try to use two things to move one piece. So like, I think just what you said earlier, which is if you internally rotate the legs first, you'll get some pelvic internal rotation from the femur, and then pelvic internal rotation from the binder. So I'm not sure what the manual says, but it makes sense, and certainly when I'm operating on a bone, if I can have two hands on the bone rather than one, it's more effective. I can push less hard on one if I have two. So maybe the foot-leg internal rotation in cravats might be something to consider.
So on this, if you wanted to add the 4 cravats, it definitely would not be overkill because you're really not probably using that top one.
Well, this is great. I just love how regimented you guys are with this. This is fantastic. I mean, you probably do this like over and over again, the same thing. How often do you go over a binder with people?
Not as often as we should. We're one of the few companies in the county that actually do carry these. Most of the folks are only going to go with the 4 cravats, maybe a sheet if they feel really spunky, but that would be the standard treatment you would expect to see at the ER with our folks coming in.
Well, great. So if you put my legs together, would you read?
No, once you're there, because we pull that, and when you hear it click, that's the design pressure. If you start doing any more, you're probably going to start doing things you don't want to.
Yeah. You want the feet internally rotated so the hips before the binders put in place?
Yes, before the binders put in place.
Okay.
So let me just think about it from an operative standpoint. If I'm operating on the pelvis, I internally rotate the feet first and lock them in place, because otherwise I'm fighting the weight of the externally rotated hips with whatever I'm doing up here.
So take the good leg, move it into the bad leg, then put the binder on.
Yeah, and then tape it, because then you're not fighting that external rotation first.
Okay, that's reasonable.
You know, so less work for the binder to do.
Good, anything else? Doc, what I missed?
Would you guys expose fully before?
Oh, absolutely. Yeah, he's trauma naked, head to toe.
Yeah, so one thing to think about, and I think one of the reasons why people put the blinders up too high, is because it will compress right over the penis, and you'll feel if there's like an engorged scrotum, it's gonna be compressed. And that's the right place for the binder. And people are not comfortable with that, so they put it up here, not feeling comfortable compressing the genitalia, when that's really where it belongs. That's where the symphysis is, immediately at the top of the penis. You know, so this is perfectly applied right there. I mean, I can't see it through your pants, but I think we're in the right spot.
That can potentially cause other injuries?
It's not going to cause, no. There's so much soft tissue there, you're not going to cause anything.
Would this blanket like this suffice to put on?
Yeah. I mean, what I'm thinking is you just need something about that big.
That's what I'm thinking.
Yeah, that's about it.
And just a cravat down at the bottom to loop around there, and you're done.
That's it. Right there.
That appears to be
a little clove hitch and done. All right, guys, we'll leave his materials out. If you guys want to come down here, we encourage you guys to practice and play with these. For those that haven't done this for a while, come on down here, put the cravats underneath, come down down here, play with the pelvic binder. These are approved in Baltimore County. Just if you guys want to add them, make sure that you get somebody out there to get you guys trained on them, and let us know. We'll be happy to come put the program on for you. Doc, anything else I missed?
I would just remind people of some basics. We spend way too much seeing time on the scene for traumas. We have to always remember to keep the wheels of progress moving towards the trauma center. Our scene times have to be compressed. A lot of the things after the initial stabilization can be done en route to the hospital. And then the second thing to remember that was stated in the lecture, cold, and it creates coagulopathy and will cause people to bleed more. This, you saw, it took some time, and hopefully with more and more practice and somebody kind of in command of the scene, things move along at a more rapid pace. It's a very different situation if you're doing this in somebody's den versus on 695. I would urge you to expedite all of this outside in the elements, even in the warmer months where people can still get very, very cold, and just be aware of the need to warm your rig up when you get the patient in there, get some blankets over them, and always keep moving towards the trauma center. Don't set up shop and operate on these people in the building, unless you're a surgeon.
Doc, anything else? Doc?
Again, it's very rare I've seen a pelvic fracture that didn't have concomitant other injuries. So, again, like this patient was unconscious. Well, he's got a head injury, he's unconscious. That's just all there is to it. And then as soon as he's got a head injury, it broke his pelvis. It could have very well broke his neck. C-collar, longboard, and as Dr. Wittberg said, we're not going to do anything other than stabilize and gift wrap and deliver. So you want to try and keep your scene time to 10 minutes. Goal an hour, still an hour. It doesn't start after the transport starts. It starts.
So to the doctor's point, who was calling a helicopter for this patient? For the one that was the unconscious trauma. That's job security for you, sir. That's conflict of interest. So, what are your rules for calling the helicopter? So, how do I get the helicopter without having to ask his permission? It got to be an Alpha or Bravo trauma. So real quick on the trauma decision tree, category alphas are what?
GCS, low.
Going to die right now, so low GCS, respiratory issues. Okay, so they're pretty much circling the drain. Category Bravos. Okay, so now you're getting into more symptomatic things, or the reasons for the trauma. So 2 or more long bone fractures, pelvic injuries. So again, if your patient's unstable, do I need to take their blood pressure to figure out if they're stable or not? I can look at them. Can I just feel a couple of pulses and figure out if they're stable? Right, so if I grab 2 pulses, neck and hand, if I've got a good neck but no hand, is that bad? Yeah, because if they had a radial pulse, their blood pressure would at least be 80 systolic. So if I don't have one of the pulses, well, if I don't have this one, you can start CPR, but I don't have this one, that's pretty bad, right? So that's why we're checking pulses. So do I even have to get a blood pressure number at that point to know my patient's unstable? Nope. So 46, are you calling for a helicopter?
Yeah, sure.
Maybe, it depends on where you turn. You turn right out of your station, you better call for a helicopter. You turn left, time of day, you may still want to call for that helicopter. Absolutely. You go straight out of your station. So 30 minutes drive time. So traffic and weather conditions permitted. If you have a category Charlie or Delta patient, so your category Charlies are what? Mechanism stuff like death in the same passenger compartment, bigger intrusion on the different sides. Say again? Overturned vehicle where they get to play pinball, or a category Delta, which tends to be comorbidity. So your patients that are diabetics, patients that have immunocompromised, patients on blood thinners, old and young, so above 55, below 5. So all these factor in. If you got a category Charlie or Delta, how do I get a helicopter? I need the consult. So remember, when you're consulting, trauma docs are standing there and everybody in the trauma team standing right there. So you better give a good head to toe and be able to describe what you're looking at and why you need that helicopter, or they're just going to say, hope the patient's alive, just bring them to us, however you get them here, and no, you can't have a helicopter. So got to be able to articulate, got to be able to give them a reason, and you've got to justify it. Remember, when you're talking to EMRC through EMRC, Syscom, the state trooper in charge of the fleet that day, is sitting there listening to the consult. How do I get to the trauma surgeon to to authorize that helicopter, when I first call EMRC, what words do I use to make sure that I get that trauma doc to authorize my helicopter? A trauma line consult. So get a trauma line consult, switch over to your talk group, give a good head to toe, give your patients vital signs, give your patients treatment of what you've done, ask for permission if you need it for something, or just for the helicopter, or if you need to do a treatment or meds or whatever, and then as the on-duty trauma surgeon, authorize or denies your helicopter, the state police are listening at the exact same time. State police hears it, I'll now divert it over for you, Adam, and so once you guys get the call from your command center to go ahead and you've got a mission to go to, what is your startup, takeoff time, and all that stuff?
So our average launch time across the fleet is about 10 minutes from the time we get the call until we're in the air. That can vary some, just there's a bunch of little circumstances that can change it, but about 10 minutes. Flight time changes depending on where you guys are. And then our standard to be on, we're trying to be on and off the scene in less than 10 minutes, the same as you guys.
So how do we accommodate you to make that happen faster?
So the key thing with us that we've noticed from transfers is just make sure your patients are fully exposed. We get a lot of patients where their clothes are not all the way cut off. So cut their clothes all the way off, because we're going to do a full rapid trauma assessment. Blankets are excellent, but make sure they go on top of spider straps, because nothing frustrates me more than I'm trying to assess a patient and there's a blanket spider strapped to them. So just key things, just do your basic stuff quickly. Times of the essence, just try and make sure you're within that 10 minutes, and like I said, the basics of exposing your patient fully, looking for injuries in every possible place, and then covering them back up and keeping them warm. Those are probably the most important parts.
IV techs, paramedics, when do we start IVs? When do we put a lock in? When do we actually hang a bag? Okay, and then what are we doing with it? Then, so you got the line in place, how long do we flow the bag? Forever? No. Until they blow up like a balloon, what are we doing? So what's your effect? How do you know it's effective?
Blood pressure over 100.
There we go. So there is a cutoff, so we do got to make sure we're paying attention to that. What might make you consult before you give that IV? Yes, if my patient's got any kind of weird stuff going on in their lungs, this may not be the best idea, especially if I'm only an IV tech level. I may want to think this one through. All right, anything else before we get into the practice phase? All right, let's go ahead and break up into a couple of groups. If you guys want to play with the pelvic binder for a few minutes, a couple of you guys want to wrap somebody up over here, we'll give you guys time to practice, and docs can look on and give you any guided suggestions that they have. Again, thank you guys for coming out here and making these programs a success.